to cut it out. Some people just cut it and take it with them. Anyway, this is kind of what a normal stomach and esophagus look like. Now, did you have much heartburn that you noticed beforehand?
I did, yes.
Okay. Well, that's the highest risk factor for cancer today is previous heartburn. Why? It's damaging this area. So you probably will have a small hiatal hernia, which is not a big deal. So yours looks like something like this. And your cancer was along this area, heads up here. So, what do we have to remove? Well, we have to remove some area above the cancer, obviously, and some area below the cancer. What we like to do is create a new esophagus out of your stomach that looks like your old esophagus, so it's going to be a tube. We save a little stomach. Why? Because we want a nice reservoir. This is enough stomach. We save enough that you'll have enough stomach to eat a pretty normal-sized meal. Not a 2-plate Thanksgiving meal, and not immediately. But in time, you will eat regular food, completely regular food. And I have many patients who tell me, I say, well, are you have any limitations? No? I say, you're eating big meals? Yeah. I say, you're not supposed to eat big meals. And the wife looks at him and says, he does it. And this. So we don't want you to eat a big meal. Why? Because it does stretch the new esophagus. We don't want to stretch it. We'd rather you... And a healthier lifestyle is to eat small, frequent meals. Much healthier than waiting all day and having one huge meal. Leads to reflux, leads to stretching of the conduit. So what we'd like you to do is eat small, frequent meals, and we'll teach you about that. But anyway, it's going to look something like that. This will come out, and you're going to have this. There's what's left of your esophagus. We save a small but important part of your esophagus, and that's the part that goes from by the base of the tongue down to the upper chest. Why is that important? That's where all the nerves are. The nerves are your vocal cords. We don't want anybody cutting in your neck. Very risky for vocal cord nerve. Now, some people who do it all the time say, oh, the risk is low. Well, in my hands, I did about 600 of those, and I had the risk down to about 1.5%. That's pretty much lower than anybody's ever published. But even in the 1.5% that are damaged, there's another 10% that have temporary injury. So they're at risk for aspiration and other things. And the 1 or 2% that get the injury, that's a lifelong problem. You can inject the vocal cord and improve it, but you can never make it perfect. So, and that operation was popularized when the cancers were higher. The cancers are lower now. We have no cancer reason to go to your neck.
Okay.
So we don't go to the neck. I would not advise going to the neck. There are people that would. Dr. Oranger, one of my favorite experts in the world in Michigan, goes to the neck. So he learned doing it 30, 40 years ago when the cancers were in the chest. Had to go to the neck. Didn't have any choice. To get around it, he had to. So now I say, why are you still going to the neck? Well, Jim, it doesn't give me a good result. And he's one of my favorites. But, I disagree with him. So, and now pretty much everybody agrees with me. So this is the new tube. There's the residual stomach down here. And this looks remarkably like normal anatomy, which I like. I always like to reconstruct things that look pretty normal because I figure, our creator had some pretty good ideas. Why change them? So if I can recreate what you were born with, I'd rather do that. So I make a nice narrow tube which recreates the esophagus. It doesn't pump, and it doesn't have a valve. Your upper valve we will leave intact, and we will leave the nerves intact. So that upper valve will be working very well. That's called the cricopharyngeus. That is important. Now, you won't have a valve, but this will be narrow, and it will not have any nerves going to it. They come out with the tumor. So the acid production of this tube is low. There's some down here, but not terrible. And we're hoping that it won't travel up this tube, because that tube is flaccid, and it does flatten out. And in our experience, we've studied this very carefully. 4% of patients have a pretty bad reflux that's treatable, and the other 90, probably 95, 96%, they say that their acid reflux is minimal. And we question people 3 months, 6 months, a year or two out. Now, everyone has reflux, I will tell you that. And the more compliant you are with your diet, the more you avoid big, spicy meals, the more you avoid all the things that people shouldn't do, like 2 pots of coffee a day, like eat a big meal and lay flat immediately. We're not supposed to do that anyway. But if you follow that recommendation, your odds are that you won't have much reflux. But you'll have plenty of stomach for an average-sized meal, and that's what the final... And the reason why we're talking about this blood supply is the blood supply comes from down here. It's got to travel all the way up, but there are some vessels that come all the way up, and we save them. And then off the side of the stomach is that piece of fat that we're going to save, and it kind of looks like this. That will come around here and will completely wrap this area. We just did one yesterday, and a guy that flew up from Florida, and boy, it was beautiful. Nice, beautiful. Yeah. And we will cut off some of the upper part of your stomach, this part, which is the riskiest part. 1, for cancer, and for 2, blood supply. Who's the furthest away from the blood supply? So if we can get rid of some of this upper tube, you have a healthier blood supply to the rest of the tube. So that's why we do it. So anyway, this approach is very popular today. I mean, I think I've even more popularized it, but it's called the Ivor-Lewis, whether you do it open or minimally invasively. That's the approach named after 2 surgeons, Ivor and Lewis. And so that's a very popular approach for your tumor, and that's what we'll do. What else do we do? Well, there's a muscle down here that we do cut. That's called the pylorus. It does help us empty a little better. And also there's a feeding tube that will go into your small intestine. It's about the diameter of this tip of the ink pen, not the whole thick part. That stays for a couple weeks. If you don't need it, you'll take it out before you go back home. But as a backup, we might say, well, why don't you leave the tube? It's held in by 1 stitch. Anybody can cut it and take it out. We'll just see how you're doing. 90% of people, we have that come out the first time they come to the clinic, which is about approximately 2 weeks after surgery. So if we do operation Monday, you'll probably be ready to go home on Friday or Saturday, home being local home, hotel, family house, friends, wherever you're staying. Are you staying family house?
Macaulay Inn, right across the street.
Then you'll stay in till Friday or Saturday, assuming everything's perfect. If it's not, we'll keep you in the hospital, whatever we need to. But assuming you go home on Friday, then we would have the tube feed already working. It's already pumping. You're getting it just at night, though. Because you're going to start taking clear liquids 1 or 2 days after surgery. And then full liquids 3 to 4 days after surgery. Now, when I say full liquids, you're going to get 1 ounce. These little cups like this, 1 ounce every hour. That's it. If they bring you a tray, that's a mistake. Don't drink it all. 1 ounce. That's the first day. Second day, we give you full liquids and 1 to 2 ounces. So if you wanted a single small scoop of vanilla ice cream, you can have it. If you wanted a single small couple tablespoons of a plain type of yogurt, it can be flavored, but not like with the big nuts and fruit in it. You can have it. If you wanted a little chocolate milkshake, you can have it. If you wanted water, apple juice, you can have it. Small amounts. Why? Because I don't want to stretch the stomach early on. I don't want to stress out the staple line. I don't want to stress out the suture line. So that means at night, starting about 6 p.m., we turn on the tube feed. Hooked up to a pump, and it runs till the next morning, usually about 12 hours. And then you get all the nutrition you need without having to push it through your mouth. You might be nauseated early on, you may not feel like eating, but importantly, I don't want to force the food early. Not worth it. Get sick, vomit, tear something. Don't want to do it. Okay? So I hope that answers everything. And now, in terms of the surgical team, generally I don't operate with another attending